Then we were told that it has to put in and most of them is used, but this is the least important.
Thank you.
So, first of all, when you're breathing.
Okay, so let me start my timer. What's your name? Chadwick? Chadwick. Did I say it right? Chadwick? Okay. Hi, I'm thank you for helping me. Okay. Who has used an ultrasound before? Who's used an ultrasound before? A little bit?
Yeah.
A little bit? Okay. So I know that ultrasound might not be as accessible, but I want to introduce you to ultrasound, how it works, how to use it. I think especially in a setting where you don't have like rapid access to a CT scanner or even a chest x-ray, this is the easiest way to assess someone and look directly into the body and the internal organs and assess what's the function of the heart. Do the lungs have a bunch of fluid in them? Is there free fluid in the abdomen? Is there hydronephrosis? All of these you can see so quickly on ultrasound. So this is just to get you guys a quick introduction to ultrasound, and specifically we're going to look at the FAST exam. The FAST exam is what we do on pretty much every trauma patient. There's 4 main places that we're looking at just the basic FAST exam. That's going to be the right upper quadrant. Can you demonstrate? Cool. So the 4 places are the right upper quadrant, subxiphoid to look at the heart. The right upper quadrant is looking at the liver and the kidney. Subxiphoid is looking at the heart. We're looking for any free fluid around the heart or in the pericardium, so we're looking for any signs of tamponade. We're looking for, over here, we have the spleen and the left kidney. We're looking for any fluid in between the spleen and the kidney. That's a potential space, just like the liver and kidney. There should not be any fluid there. If there is, in a trauma setting, I'm very worried about intra-abdominal bleeding. Now, if this was somebody with chronic alcoholism and had liver cirrhosis for whatever reason, ascites would also give you a positive FAST, but that isn't in the setting of trauma, so I'm not so worried about internal bleeding. And then the 4th place is suprapubic, where you're going to look at the bladder, and we're looking for any free fluid outside the bladder wall. Now, any fluid in the body on ultrasound is going to be black. When you look at the bladder, you're going to see black in the bladder wall. That's urine. We know that that's supposed to be there. But any black that we see, any pocket of fluid that we see outside of the bladder in the setting of trauma is very concerning for bleeding. Okay, so Davis is going to give us a little example.
That's a really good technique.
Okay, and you want to introduce them to the probe and...
This is the probe marker. It's either facing the patient's head or facing not the other way, because it will give you an inverted image. Okay, we go for this place, the space between the liver and the right kidney.
And
the
this is,
space.
Go ahead.
Normally, the paternal space or Morrison's pouch. So,
all right, so on here, we're seeing this is the liver, this is the kidney. So just to orient you, this part right here is right where the probe is touching the skin. So this is the most superficial. As the ultrasound waves go through his abdomen, so you see that he's touching skin, and then you see liver, and deeper you go, you see kidney, okay? So this space, see that bright white line between the kidney and the liver? That is, we call it Morrison's pouch. That's a potential space, right? In a normal healthy person, there should be nothing there. We should just see a nice bright white stripe. If he was a trauma and hit by a car and internally bleeding, I would see black space separating the liver and the kidney. And that would be a positive FAST. That would be blood that's in the abdomen, that's collecting in that space. Okay?
So this bright border is the diaphragm, and if you also find free fluid below the diaphragm, that means there is free fluid in the pleural space. Free fluid below the diaphragm. This is the diaphragm. If you find black, okay, free fluid is in this region. That means there is a pleural fluid.
It could be a hemothorax. If it's a sick tuberculosis patient, that just might be just any just fluid from the infection, and they just have a pleural effusion. And I almost always, I do the right upper quadrant first. In a patient that's supine, that's a trauma patient, that is that's kind of the first space that fluid will start to collect. Now, of course, if they have trauma to the chest, and I'm more concerned about chest trauma, I'm going to look at the subxiphoid first and take a look at their heart, make sure they don't have tamponade. But I typically start with the right upper quadrant.
Also, you find even in the case of ectopic, ruptured ectopic, that's a non-trauma case, there will also be free fluid around the space.
So sometimes a pregnancy test might take a really long time to come back, and this person maybe hasn't had a period for 3 months and is having excruciating abdominal pain and is hypotensive. I want to know if they have free fluid in their abdomen, because then that's really an ectopic pregnancy until proven otherwise. All right, so let's... Oh, you want to do left upper quadrant? Okay, so we're going to do left upper quadrant just to compare to the other side. So quick thing about the left upper quadrant. On this side, we had liver pushing down on the kidney. So it's going to be, that space is a little bit lower. On this side, we don't have a big liver pushing down on our kidney. So you're going to go a little bit more superior on the patient's body, and it tends to be a bit more posterior. So let's take a look. Beautiful. This is the spleen.
And this is the left kidney. So you are looking for the space between the spleen and the left kidney. This bright white.
Yeah, that bright white is the two organs touching. We should see bright white. When we start to see black in between there, that's blood.
Also, like the other case, if you see free fluid here, can be effusion, can be hematoma, any free fluid here, you should also report for that.
All right, let's see our subxiphoid. So this is the time where the indicator is to the patient's right. All right?
I'm checking the heart.
So what's this thing?
That's a heart.
Yes, great. Okay, so remember, just to orient us, his probe is touching skin. It's still going through a bit of the liver that's extending over, and then we go through that bit of the liver to the heart. This is not me trying to calculate their ejection fraction. It's nice to look and be like, is it normal looking like 60, or is it super reduced like 10? Then I'm more concerned. But really, I'm mostly just trying to assess very quickly, is there fluid in the pericardium? Is there concern that this person is going to develop tamponade or has tamponade physiology? And that's all I'm really looking at in this field.
Can also try there are many views for the heart. There's also this.
For our purposes, for FAST, it's fine. We just look at the subxiphoid. Doing a full echo on someone is very complex. We just want to make sure that there's no fluid around the heart, which we can say pretty confidently here. I don't see a bunch of fluid outside that white line of the heart. Okay? And then the fourth thing we're going to look at is the suprapubic, that we're going to look for the bladder and make sure that there's no Make sure that there's no free fluid outside the bladder. Remember, so this is bladder, and I see black. And I just told you, when we see black, it's fluid, and we have to be worried. Except, he has a bladder right there. We know his bladder has urine in it. We're looking for any black outside of this wall of the bladder.
This black is not the same as that of fluid. I have to see the difference. Is this dark region here? It's not okay. That is the rectum. Yeah. So you are trying to find free fluid around that.
All right, so let's get you guys doing it.
The thing to know about this is there's obviously a lot of power, so you don't have to push it. You're gonna just let the drill do it, okay? And
Beautiful. So we're already starting to see a very important organ that is the liver. So here's our liver. But now where does our kidney live?
So this was a pediatric patient. This was a 6-year-old.
Oops, sorry. You can also, you can also just go down. So we're seeing liver. Now we just need to, right? We're going to find it. I promise you have both kidneys, right? No, we already saw it. I know you have both kidneys. Oh, it's coming right there. Beautiful. So here's liver. Here's kidney. What's this white line? What is it? Morrison's pouch. That's a potential space. He has no free fluid in there. Yay. So you have a beautiful view. Amazing. Okay, now let's move to subxiphoid.
So look at the size of this.
So this is your... The way that I think about this view is almost like you're taking a spoon and scooping under the xiphoid process. And you have a great view right there. So there's our heart. We see cardiac motion. And again, we don't see any big collection of fluid around the heart. And then just lightly where you are, just remember, see, if you did subxiphoid and pointing like this, is that going to get his heart? No, his heart's up here. That's why we have to aim towards the heart. Beautiful. Yep, gorgeous. And then left upper quadrant. Now remember, always look where the indicator is. Where do you want the indicator? Beautiful. So remember on this side, it's, sorry, I'm going to move your arm out this way. It's more down towards the bed and up towards his head. And that rhymes, and I feel very proud of myself. Okay, there you go. All right, so what's this?
This is a spleen.
And what's this?
It's a kidney.
And what's this white line? Splenic renal space. It's a potential space, and we just see it as bright white because it's the two organs touching. We want to see bright white. Okay, and then we'll go to your suprapubic view. Ooh, okay, so now remember, you can do it either way. I prefer to just have it the indicator towards him, towards his right. Yep. And then remember, where's our bladder? It's a little low down, so you're gonna fan down. Exactly. Crossing. Good. Feel good? Okay. All right. Switch. You good? Are we hurting you? Okay. Yeah, grab a little gel. All right. Does he have a good view? What do we think? Can you point to the kidney?
And I didn't know if we said this, but when you're trying to push your needle, if you put a syringe,
That whole thing right there. Okay, let's get a better view of the kidney for me. Could you point to, oh no, and yeah, we'll keep you. Could you point to the liver? Let's get a better view of everything. Yep. Can you point to the liver? Yes. Can you point to the kidney? Can you point to Morrison's space? Yes. Beautiful. Amazing. Okay, let's do the subxiphoid. And I'm sorry, what's your name? Hamed? Nice to meet you. So this is the scoop, and remember, where's our heart? It's right here. Maybe a little bit more gel for us. We need a little bit more gel. There we go. Beautiful. Okay, left upper quadrant. Now remember this one. If you hold the probe like this, it's knuckles towards I always tell my residents it's knuckles towards the bed. So it's much more down towards the bed. And up towards. Also, where's your indicator? So the indicator should face up towards his head. So you need to go a bit further down. You have kidney, and then slide up a bit towards his head.
So this is an
We need a lot more gel, guys. We need more gel.
Use the typical
A little bit more towards his head. There we go. We're starting to get, what's this?
It's a kidney.
Kidney, what's that?
Spleen.
Yeah. There we go. And what's that white line? Yeah. Cool. And then we'll take a look at the suprapubic, our last view. And remember, where's your indicator? Is it? Oh, it is. Okay, good. Where's bladder?
There it is. The top.
Gorgeous. All right, perfect. Nicely done. Okay. How do you feel about that view? Where's your indicator? Yes, okay. Good view. Okay. Where's the liver? Can you point to the liver? Yes, where's the kidney? And where's Morrison's pouch? Beautiful. All right.
And she talked about using vitamins during the first
We need a lot more gel down here. We're working with.
So I'm not sure if
There we go.
the study that they did on live weight, volunteers, which were really they said that inserting an IO was painful, but using was when it was cool. So it was not so painful to insert, but it was more painful to use. So we do something initially.
Good luck.
Sometimes the subxiphoid can be hard after people eat because they've got like food in their stomach and the intestines are moving a lot, so it can just be a little bit harder to ultrasound people in general after they eat. Okay, there we go. There we go. Beautiful.
Over 2 minutes, or 2 times 2. That's
All right, and then we're gonna go to the left upper quadrant. Remember, this is more posterior and superior. Okay, can someone point out the spleen? Where's the spleen? Yes, this is the spleen. And where's the kidney? And where's that recess? Recess, perfect, beautiful. Okay, and then our last view. And then who did we start with? You started, okay. So you guys haven't gone? The three of you? Okay.
Let's see, what else? We talked about application. Talk about all the applications. There are other sites available. theoretically, anywhere there's bone marrow, but in pediatrics, not uncommon, you can see distal malleolus, just go about 2 millimeters. Yeah, surface again on the tibia.
Good? Yeah.
Here and it did work.
All right.
Down here, the whole right bone. There is also a femoral.
3 more. Got it. Thank you so much. All right. Please tell me this patient was hit by a car and he has so much abdominal pain. You're doing good. You got liver, fine kidney. Beautiful. Monica, where's the kidney? That's liver. Yep. Morrison's pouch. Yeah, that's that potential space. Gorgeous.
Okay, no problem.
Yeah, take your clothes off.
So sometimes you don't need quite as much pressure. So I'm starting to see cardiac motion there.
Better than this one. This was the knockoff version. So we're gonna keep some.
Now again, sometimes if you have trouble finding it, you can look over and on the chest, on the chest wall here.
But the lithium batteries, so it's like, wow, I don't think I put that right. And then these, like,
There you go.
yeah.
All right. This is his left ventricle right here, because it's thicker, and you can see there's no free fluid out from outside in the pericardium, outside the heart. Okay. All right. So if you're having a hard time there, you can always look on the chest wall, anterior chest wall.
So you adjust it, and you just twist this little piece around. You don't have to force it, but do it because trigger activated, just push down.
Okay. Let's move to left upper quadrant.
Oh, dear.
Where's the probe marker supposed to be?
Like I said,
Facing up towards the patient? Yeah. Perfect. All right, so now we know that the kidney on this side is a little lower and a little higher up towards the patient's head.
yeah, obviously what you do, you kind of
Getting
come up so you
close.
put the stethoscope.
Try going a little bit more posterior. There we go. We've got kidney wheel coming into view. There we go. Okay, we're starting. So where is kidney? This is kidney. This is spleen coming into view. Hold on. This is the spleen right here. This is the kidney. That's the recess. Okay? Lovely, lovely. So you can have it this way or the indicator towards you.
You do LMAs as well.
I don't have it covered.
Well, let's see how the Pro is. The Pro is a Pro.
Oh my gosh, there's black. That means there's fluid, but what is that? Okay, all right. Cool. Thank you so much. And then you two are the last ones. Can you tap my phone and see what the timer says? All right, let's do this. 2 more in 7 minutes. Thanks. Oh, sorry. We're like totally throwing support over your face. Oh, gorgeous. Beautiful. Getting there. Do you see what you want to see? Is that a good view to you? Do you like that view? Okay, where is the kidney? Or here, you ultrasound, I'll point to something, you tell me what it is. Okay, what's that? It's slipping, what's that? What's that? Love it. All right, to the subxiphoid.
See those chords? You want to watch that goes through the chords.
So you don't have to push so hard on him. This is actually a very tender place to push. And he's being very stoic, but it's very comfortable. Yeah, and if you're having trouble, you can always go in across the chest wall. There's a lot of different views of the heart. We're not going to get into all of them. But this is easy where you can say, okay, I don't see any big fluid around the heart.
Yeah. Otherwise, the needle will start twisting on the skin and it will pull the skin and it will just
it's harder. So you go in, straight in, hit bone, and then it's and on that side, it's a little weird because it's so far in. You're doing it 100 miles. Yes.
Are you an athlete?
Yeah, there's okay.
You know, your heart rate's just like chill. All right. Left upper quadrant? Where's your indicator? Good. Upper quadrant.
And it connects, and it's actually almost a little bit difficult to pull off.
What's kind of a little bit, go a little bit more close to your eyes? Maybe a little bit more gel. Oh, we found some vertebra back there. Cool. This is a little too low. There we go. What's this?
Spleen.
What's this?
Kidney.
Beautiful. Let's find that bladder one more time. There you go. This is like the easiest one to get, right? You know where the bladder is, you just stick it right over it. And even just using the ultrasound, what you don't know if somebody's necessarily retaining urine. What if they're in like crazy kidney failure and you can't figure out why and their stomach hurts? You can just put this on here and be like, oh my gosh, your bladder's huge. Let's put a Foley in and decompress. So super easy just to get a lot of information very quickly with the ultrasound. All right, last one. Let's do it. Do you guys have any questions?
But there is how much does it cost? So when you use your patients in the OPD, you can see for those trauma patients.
For trauma cases, just
Feel good about it? You like the wait, go back to your view. Show it off, it was so pretty.
You'll often have like dressing.
Oh, hello, Morrison's pouch. Beautiful view, love that. Liver, kidney. All right, subxiphoid. Good view.
How much are they?
And then we can go to left. Get a little bit more gel. This one has. No, you're doing great. You're also in slippery gloves. Where do you want your indicator? Up
First
first.
the head.
Way better. Way better. Yes, this is way better. Or the 18 gauge ones in practice. Those work just as well. They're just a little bit less, like,
So that's
they're not designed for the really.
You want to go down a little bit more?
90% of the time.
There. Davis, can you quit the stand? That's a very good view. Good. Okay. And then one more time on that bladder.
Sorry. Really, not if you're doing this and you're you know, it's almost like there's more active force. Use your body. Yeah, to get it in.
All right. Okay. Oh.
Question. In a trauma setting,
Yes.
in the
This is designed for the.
or you're doing a POCUS.
When I'm doing focus, yes.
Okay. When you are quantifying the fluid, do you quantify as massive or just want to say it's a positive first whenever there is blood?
Or so you're saying, do I say positive or do I quantify it?
Yes.
usually we don't quantify.
Okay.
For internal bleed, it's either positive or fast or negative. Yeah.
So I also should clarify, to get a positive fast takes a good amount of blood. So if you see a positive fast, it's positive. The person has free fluid. In a trauma, it's blood until proven otherwise. But if the person has a very tender, like very tender abdominal exam and you had a negative fast does not rule out bleeding. It says there's not enough blood for me to visually see it right now, but there still can be internal bleeding. I'm just not able to see it on the ultrasound. So a positive fast is like, yes, there's fluid, we see it. But a negative fast doesn't totally rule out that there is internal bleeding. Or that there isn't internal bleeding.
When we are looking at the suprapelvic region, there are three structures we are interested in: the bladder, the rectum, and the prostate.
Okay.
Not in a fast.
In a fast?
In a fast, that we don't worry too much about that in a trauma setting, right? I just want to know, is there free fluid? But maybe you can speak to more internal medicine.
Okay. For the case of fast, just looking for free fluid outside the bladder. We just want to know if there's internal fluid. For other abdominal ultrasound, your interest is on prostate, the ureters, and all that. But for fast, just free fluid.
Yeah. I'm not even trying to find the rectum or the prostate. I want to just do quick, can I see free fluid in this abdomen? Does this patient need to go to the operating room now? Yeah.
And are you from usually look at the distinction between blood and excess fluid?
Right, because when you look at the bladder, what you see inside the bladder that we know is urine is exactly what blood looks like, is exactly what someone with ascites looks like. If you look in the eye, it's exactly what aqueous humor looks like. So you can't tell by looking at it what type of fluid it is, but in the setting of a trauma, it's blood. And sometimes, you have someone with liver cirrhosis in a trauma. Is it a positive fast, or is that just their ascites? That wouldn't be able to tell.
Maybe one last question. In a setting where you are not able to access the ultrasound, what other mechanism will you use to confirm if there is blood there?
So people used to actually put a needle into the abdomen and do this lavage to see if blood came back. We do not practice that anymore. I would not recommend including that in your practice, but I'm sure, Mel, for traumas, before you used fast, did you stick needles in bellies and look for blood?
We did, but not much.
Yeah, so Mel has done it a few times. Since I've been trained, that's never been in practice. Yeah.
Thank you.
So I don't suggest it.
Okay, thank you.
Yes.